Hello, everyone. My name is Kristen Johnston, and I am an oncology nurse and the lead case manager at Massive Bio. I have an extensive background in oncologic nursing and clinical trial recruitment and management at the University of Pennsylvania prior to joining the team at Massive Bio. I am very passionate about total care for the cancer patient and their family members. Today is September 27th, and this is a recorded webinar sponsored by Massive Bio. We will have two sessions today at 1 p.m. and 6:30 p.m. Eastern Standard Time. Our focus will be on pediatric malignancies. I want to provide a brief background on Massive Bio before we move on to the discussion on pediatric malignancies. Massive Bio brings the latest knowledge in cancer care to patients treated at community practices in the U.S. and worldwide. Massive Bio not only provides cancer patients with access to best practices, but also solves the pharmaceutical industry bottleneck for clinical trials and drug discovery, because 85% of U.S. cancer patients are treated at community practices and are not readily accessible to clinical trials. Massive Bio translates the world-class precision oncology knowledge of large cancer center experts through a virtual tumor board, and then helps the patient and treating oncologist to operationalize these cancer expert recommendations at the point of care. Massive Bio can also facilitate bringing the patient to a large cancer center if local treatment is not available. Massive Bio reduces the time, travel, and cost burden for cancer patients. All the while, Massive Bio extracts intelligence from data through combination of clinical history, genomics, and outcomes to improve current and future patients' lives. Massive Bio supports cancer patients and their family members throughout their entire cancer journey. Next, I would like to introduce the oncologists who will be partaking in our webinar today. First, we have Dr. Jason Freedman. He is a Chief Pediatric Advisor of Massive Bio. Dr. Freedman also works as a pediatric oncologist at Children's Hospital of Philadelphia, with a focus on stem cell transplant and supportive care. Thank you for joining us, Dr. Freedman.
Thanks for having me.
Next, we have Dr. Gerald Wertheim. He is a hematopathologist at the Children's Hospital of Philadelphia. Dr. Wertheim has a particular research focus on acute myeloid leukemia and molecular diagnostics in cancer. Thank you for joining us, Dr. Wertheim.
Thanks for inviting me.
And finally, we have Dr. Sarah Tasian. Dr. Tasian is a pediatric oncologist at Children's Hospital of Philadelphia with a focus on leukemia and precision medicine. She is nationally known for work in acute lymphoblastic leukemia and has a strong research focus in this area. Thank you for joining us, Dr. Tasian.
Thanks very much.
So today we are going to go over a basic overview of pediatric cancer. We hope to help you understand the techniques used to diagnose and understand the behavior of cancer. And we also hope to talk about precision medicine, which is the new evolving field of using specific diagnostic components of a cancer to find treatments very specific to the patient. A basic overview of pediatric cancer would show you that pediatric cancer in general is very, very rare. Only about 12,000 or so children less than 20 years of age are diagnosed with cancer each year. That is compared to the nearly 1.7 million cases of adults diagnosed with cancer each year. For children, it is the second leading cause of death in kids less than 20 years of age. And as opposed to adult cancer, where we know certain risk factors exist, like smoking or environmental exposures, there's very few known risk factors for pediatric cancer. If you take a look at this pie chart, this is the breakdown of the types of cancer that children often experience. As mentioned, in adults, many of the tumor types are considered carcinomas, or cancer that arises from the lining or covering of the organs. For example, those are tumors like breast cancer, liver cancer, thyroid cancer. In children, those type of cancers are very rare. In children, the more common form of cancer, and the most common, is leukemia, as you can see on the right side of the pie chart. Acute lymphoblastic leukemia, or ALL, represents nearly 35% of cancer experienced by children. The next most common is CNS, or central nervous system tumors, such as brain tumors and spinal tumors. Starting from the top of the pie chart, you can see going down the left side, the other types of tumors that affect bone, muscle, kidney, and liver make up a much smaller number as compared to adult epidemiology of cancer. With that said, survival rates for children with cancer have improved with newer, more effective, safer treatments. You can see that looking at patients from the 1960s all the way up to the current era, 80% of children approximately will survive their cancer. However, there's still a lot of work that needs to be done, as several types of cancer have very poor survival rates, and we really must work hard with research to find cures for these children. Treating cancer is not a one-size-fits-all model. Different tumors are treated with different recipes, for example. The types of things we use to treat cancer include those on your screen. Chemotherapy is the mainstay. This is medication that is designed specifically to kill tumor cells. Surgery, when applicable, involves the physical removal of tumor cells from the body. Radiation therapy uses high-dose energy to kill tumor cells with energy waves and zap them. Immunotherapy is a very unique type of treatment, which harnesses the power of the immune system and makes one's own immune cells fight against the cancer. You may have recently heard this month that the FDA approved a groundbreaking therapy for children with leukemia treated in this way with immunotherapy. Stem cell transplant involves high-dose chemotherapy to kill cancer cells, but also make space inside the bone marrow, or the cavity where all of the cells are made, and transplanting a patient with new stem cells. This removes residual cancer and provides new cells to create a brand new immune system, which hopefully keeps the patient in remission by an ongoing immune surveillance. Oftentimes, combinations of these therapies are used. For example, in leukemia, both chemotherapy and radiation are used together. In solid tumors, such as bone tumors, chemotherapy, surgery, and radiation may all be used together as well. Thanks to the work of many cooperative groups, such as the Children's Oncology Group, and groundbreaking research, we have been able to develop protocols that combine these modalities to provide consistent standards of treating cancer, no matter where the child is located throughout the United States or the world. Clinical trials, as you may have heard of, are often used for more relapse or refractory cases with newer drugs. But many of the studies that have brought treatment to where it is today is the result of ongoing clinical trials. I should just mention quickly that treatment for cancer is not trivial. The side effects of it are significant. You can see in front of you the physical effects have the chemotherapy, radiation, or other modalities have. They cause a need for blood and platelet transfusions. They put a patient at risk for infection. They cause toxicity to certain organs, such as the brain, heart, liver, and kidney. They may cause hair loss, nausea, weight loss, and pain. Psychological issues that affect the child with cancer, also the parents and siblings of that child. And there's many late effects, meaning things that affect the child many years down the road from having had therapy for cancer, such as growth issues, thyroid issues, and potentially infertility. Treatment for cancer also can increase the risk that a patient will undergo secondary cancers. So therefore, our goal is to decrease the side effects of cancer therapy and more effectively and more precisely treat cancer. And again, cancer is not a one-size-fits-all. Different therapies and combinations of therapies must be used, and we need to reduce the side effects and the late effects of treatment without sacrificing the cure rate. We need to use several lab techniques to diagnose the specific types of cancer, and then we match those with specific treatment for specific patients. To describe how we diagnose cancer and how we find those special characteristics of the cancer that might be helpful to better treat patients, I turn it over to Dr. Wertheim, who is a pathologist with us, and will guide you through a look into the diagnostic techniques.
Thank you, Dr. Freedman. I would just like to discuss Some of the techniques that we use to diagnose pediatric cancers, as well as some of the techniques we use to look at how those cancers might be treated and what the prognosis of the patients are. And that really involves a complete pathologic assessment of a tumor. And when we do that, when pathologists do that, what we need to do is we need to look at the tumor cells and basically say, is this cancer or is this not cancer? Obviously, that is an essential question, since we certainly don't want to treat patients who don't have cancer as if they did. And we want to make sure that we give a proper diagnosis of cancer to patients who have it. We then like to subtype those cancers and basically say, is this cancer, say, a solid tumor versus a blood tumor? So essentially, in the pie chart that Dr. Freedman showed, the lymphoblastic leukemias, the acute myeloid leukemias that were on the right side versus, say, the CNS tumors or other types of tumors that were on the bottom right as well as on the left of his pie chart. And from there, with that subclassification, we can go even further into those categories and get other specific categories which may have different modalities to treat them. We also want to look at different features of the tumors that could influence both the treatment as well as the prognosis of them. And those include, say, proteins that are expressed by the tumor cells, either within the cell themselves or on the surface, as well as what the genetic changes are. So what are the changes in the DNA that might affect, say, the treatment of the patients as well as their outcome. And I think our main goal when we give an overall diagnosis is really to give the clinical team all of the information that we can get that we think is necessary for them to treat each specific patient in the optimal way. The way that I like to think about, say, a complete diagnosis is essentially if you were going out and buying a car and using the car analogy. So the first thing that we like to do is basically say, is what I'm looking at really a car, or is this what I'm looking at, say, a cancer? And pathologists mostly can do that instantaneously, as I'm sure most people can do if they look at something and say, is this a car or not? Sometimes that gets a little more difficult, both with, say, pathology, or say if you're buying a smart car, which doesn't look like a car at all. Then what we like to do is we like to say, what subtype of cancer are we looking at? And essentially that's like saying, are we looking at a minivan or a sports car? And again, this tends to be easy. If we're saying, is this a solid tumor versus a blood tumor? Just as it's easy to say, is it a minivan or a sports car? But again, there are some distinctions that may be difficult, especially when we get to further subclassifications, saying what type of tumor is this within it, which is like saying, is this a Toyota or is this a Honda? But really what we want to do when we're buying a car is we want to know how that car can actually function, say, 10 years down the line. And are there problems that are going to arise with it? And what we'd really like to do is get in and know all the specs about that car in order to say, is this really the right car for us? And we need to know what's happening. And that's essentially where the genetics comes in. Next slide. So just to go into some of the steps that are involved in diagnosing a cancer. The first thing that we do when the pathologist looks for cancer is we need to get a sample of tissue. And that sample can be anything from blood to, say, a fine needle aspirate, where a doctor can basically take a very fine needle and go into a patient's tumor or in a patient's tissue and pull out some cells that we can look at. We can look at needle core biopsies, which basically are larger gauge needles that can pull out cores of tissue, or we can get a surgical resection specimen. We then take part of that specimen and we look at it under the microscope. And this is essentially when we make the diagnosis of cancer versus not cancer, and that tends to be quite easy to do. The two pictures that I'm showing there are pictures from a patient who has acute myeloid leukemia, and essentially we can look at those, pathologists can look at those and very easily tell that that's cancer. The next step is to subclassify the tumor, and that's essentially looking at specific features of each cancer to figure out if it's solid or if it's hematopoietic or if it's a blood cancer, as well as to say what are the specific proteins that are expressed by the tumor to further subclassify that. And there are a number of techniques that we can use to look at that. Most of them involve probes for proteins, And we can either use those probes to, say, turn tissues different colors. So that's what's on the left side in the figure. Or we can use special techniques using some instruments within the lab that basically can look at different proteins that are expressed by the cells. And that's what's shown on the right. But perhaps the main feature of the cancers that we really have to assess are the genetics, because that's really where the money is. And that's what we need to look at to say, how are these tumors expected to behave? Are there specific treatments that we can use for these tumors? And really, can we give the oncologists information on the genetics that they can use for, say, precision medicine? There are multiple modalities for testing of the genetics. Many of these modalities have specific advantages and drawbacks, and these include the resolution. So how far down into the DNA sequence can we actually look? How much of the genome is covered? How sensitive these tests are, and then what the cost of these tests are. Next slide. So just in terms of the genetic resolution, probably the least fine resolution we can look at is basically the chromosome. So humans have 46 chromosomes, 23 pairs of them. These can be seen by the light microscope with just some staining. And essentially that's a low resolution technique that we use, but it can give us a lot of information. Chromosomes, if we can go back for a second. Chromosomes have genes within them. So those are regions of the chromosome that code for certain proteins. And then if we go further from looking at genes, that those are composed of nucleotides, and that's essentially your DNA sequence made up of the A and the G and the C and the T sequence that are the nucleotides within the DNA. So when we look at cancer and we look at the genetics of each tumor, the first thing we like to do is known as cytogenetics, and that's low resolution evaluation of the genome, which is basically looking at each chromosome. And so what we're looking at on the bottom left is a karyotype, or just every single chromosome within a cancer. And if you notice that there is an arrow pointing to chromosome 8 and an arrow pointing to chromosome 16, and those two chromosomes are abnormal, and that actually specifies a lot of information that we can get from this tumor. The second method that's typically used to look at the genetics of each tumor is called fluorescence in situ hybridization, or FISH. What we're doing there is we're essentially looking at genes or certain regions of each chromosome. And the way we do this is by using specific probes to genes that have a fluorescent tag, and so we can see them using different types of fluorescent filters. And what you can see in the bottom right is that we've used two probes to two different genes that give a fluorescent signal. In the normal, you can see that there are two green signals and two red signals. However, in the abnormal cell in the bottom right, there's one green signal, one red signal, and then you can see that the two reds and greens have mixed. And that's essentially showing that there are two regions of the chromosome that have come together. And again, what we know there is that we have something that's abnormal, and that gives us a lot of information about this tumor and what the genetics are. And then probably the most fine resolution that we can do is essentially looking at sequence, the actual DNA sequence. So there what we're doing is we're looking at each individual base within, say, a gene, the A, the G, the C's, and the T's, and we can see single base pair mutations. Traditionally, when we do this, we need to use specific molecular biology techniques, and typically, or say up until about 2 or 3 years ago, we could only look at, say, 2 to 3 genes at a time, since these were very specialized techniques, and we'd have to do multiple rounds of testing for each gene. However, now there's a new technique that's being used more often in many molecular biology labs and in clinical molecular biology labs, which is next generation sequencing. And essentially what next generation sequencing allows you to do is to look at individual bases, so to get sequence information, but you can get that from multiple genes. And that can be, say, anywhere from hundreds to thousands to millions of genes. You can look essentially across the genome and see what the actual sequence is for every single base in the human genome. So the question that we have for cancer is really, what are we going to sequence? Most labs will say we can take a number of important genes and we can sequence them. However, more labs are now starting to move towards, say, whole genome sequencing. However, this is still quite expensive and takes a lot of analysis to do. The information that can be obtained from next generation sequencing is actually massive. You get a comprehensive genetic blueprint of a cancer. So you can see multiple base changes. You can see if DNA has been lost, if it's been gained, if it's moved from one place to another, if it's inserted itself into regions where it can't be. So there's essentially a massive amount of data that can now be generated for each tumor. We can basically go and look at the specs on every single tumor to see how these may behave in the future. And basically to say, you know, do we think that these are going to respond to certain types of treatment? So the goal of the pathology evaluation, you can keep going. Goal of the pathology evaluation is really to look at morphology and to say, is this cancer or not cancer? To look at protein expression, to subtype it, but really to get it to the genetic features of what is abnormal, what's really important, and then basically to take this back to the context of specific patients for specific cancers, and to say, what are the therapeutics that can be used? And I will now turn this over to Dr. Tasian, who will say how we can use some of that information to guide therapy.
Thanks very much, Dr. Wertheim. So I'll now discuss some of what we've learned through the genetics of sequencing tumors and how we can really apply that in real time to the treatment of patients who have these genetic changes or mutations. And the goal of precision cancer medicine for both adults and now in pediatrics is to improve cure rates and to decrease side effects by identifying dependencies within cancer cells, such as changes in genes or proteins or pathways that are responsible for causing the cancer to either form or to progress or relapse. And then ultimately to use what we call targeted therapies or precision medicine to attack those Achilles heels or specific vulnerabilities caused by those genetic changes so that we can better kill the cancer cells. When we think about treating patients with cancer, a lot of times we don't know who these patients are when they walk in the door, and we treat them with very non-specific medications such as chemotherapy or radiation therapy or surgery. Through the power of precision medicine, we are now able to take this sort of gamish of patients that you can see here in the example on the left, and looking at the different genetic changes or the patient's responses to the treatment, put them into different bins such that we can more precisely tailor their therapy so that patients get exactly what they need and no more or no less. And the goal of all of this matching mutations to the medications is to treat patients to achieve cure, but perhaps also to minimize side effects or unwanted sequelae of these very strong treatments. Next slide, please. This gives you an example, perhaps, of how a patient would come to you seeking a precision medicine therapy. For some patients, we do an informed consent process to do specific genetic sequencing, such as what Dr. Wertheim just laid out for you in terms of next generation sequencing. We process the samples, we analyze them, and this time can take quite a bit of time. Ultimately, doctors study what the genetic changes are within the cancer cells via a precision medicine tumor board, and then we can relay those results back to the treating doctors or to the patients and their families, ultimately with a goal of finding a specific medication or a precision therapy that may benefit the patient. Next slide, please. I'd like to share two examples with you specifically in the pediatric setting. The first is a brand new trial that is run through the National Cancer Institute and the Children's Oncology Group in North America that is called the Pediatric Match Trial. This is a brand new phase 2 clinical trial that is enrolling children and adolescents ages 1 to 21 years of age through the Children's Oncology Group who have relapsed solid tumors or solid tumors that have not responded very well to chemotherapy. And the purpose of this trial is to assess the ability to match a targeted medication to a specific cancer-associated genetic mutation and to help us understand how well children may respond to these treatments. Currently, as Dr. Wertheim alluded to previously, we can test for tumor changes in cancer genes up to between 100 and 200 genes. Currently, this trial will assess mutations in up to 160 genes. And then we will bin patients into specific subsets such that a targeted medication may be relevant for that patient. And shown to the right in this table, this gives you an example of what the different 8 medications are that are currently under study. These are all medications that are very exciting in adult cancers, and we're hoping to explore them as well in pediatrics. And I think what is very powerful about the NCI-COG Pediatric Match Trial is that over 200 children's hospitals in North America, England, Australia, and New Zealand will be able to participate in this trial. And because pediatric cancers are rare, we believe that putting our heads together will really help us to understand in a larger subset of patients how well some of these medications may treat certain cancers. Next slide, please. A second example is in leukemias, and I want to highlight something that is called Philadelphia chromosome or Ph-positive acute lymphoblastic leukemia or ALL. As Dr. Wertheim just mentioned, we use cytogenetic analyses to characterize genetic changes in some kinds of cancers, including acute lymphoblastic leukemia. One of the earliest genetic changes that we learned about were responsible for causing cancer is one of these cytogenetic translocations in which one chromosome breaks off and connects to another piece of another chromosome, and that forms something called a fusion gene or a fusion protein that doesn't normally exist in nature. And in the Philadelphia chromosome positive ALL, this fusion gene or protein is called BCR-ABL. We know that children, as well as adults who have this fusion in their leukemias, have a very high rate of leukemia coming back or relapse, as well as death when they are treated with conventional chemotherapy. And we learned about 2 decades ago that a medication called imatinib, which is a tyrosine kinase inhibitor, or TKI, can specifically target this abnormal fusion protein and kill the cancer cells. And we learned through clinical trials about now 15 years ago that when you add imatinib to regular chemotherapy for children who have Ph-positive ALL, we can take their relapse-free and overall survival from about 35% to 80%. And I think even more importantly, we are now able to use imatinib in chemotherapy and spare these children the need to have a bone marrow transplant, which is associated with a lot of long-term side effects and toxicities. And because of this success, which I think has really been a paradigm for precision medicine in pediatric cancer, we are now actually looking at adding these tyrosine kinase inhibitors, such as imatinib, with less intensive chemotherapy, with the hope of maintaining excellent cure rates and survival, but perhaps minimizing some of the toxicities that our patients experience with very intensive chemotherapy treatment. Next slide, please. Another example, I think, inspired by the paradigm of Philadelphia chromosome positive ALL is something that is very newly discovered that we call Philadelphia chromosome-like or PH-like ALL. And this has turned out to be, in about the last 5 years, a fairly common subset of pediatric leukemia. And we know that like PH-positive ALL, PH-like ALL is associated with very high relapse rates and very poor overall survival. And we are hoping to now use the precision medicine paradigm of imatinib for children with Ph-positive ALL and apply that to children with PH-like ALL such that we may be able to use precision medicine therapies to improve their outcomes. We now know through things like next generation sequencing and other precision medicine diagnostic tests that PH-like ALL is caused by several different kinds of genetic mutations that all commonly lead to activated signaling networks within the cells, somewhat like a telephone wire network that can be a bit loose-wired. We now know that some of these mutations can be targetable by certain drugs, again called tyrosine kinase inhibitors. And this is another example of how we are now using precision medicine in pediatric oncology. There are 2 current Children's Oncology Group clinical trials that we are looking at the addition of a kinase inhibitor, either dasatinib or ruxolitinib, for patients who have certain genetic mutations. And we now know, because this has been a fairly successful approach in pediatrics, that we are teaching our adult cancer colleagues about how to use these medications in adults who have a similar type of leukemia. Next slide, please. This gives you, I think, a bit of a futuristic example, but highlights the potential for precision medicine diagnostic testing as well as therapeutic options in pediatric cancer. And this just gives you an example of the variety of different kinds of medications in precision medicine that are currently being tested in the laboratory as well as now in the clinic for children who have Philadelphia chromosome-like ALL. So I think that this is a very exciting time to be understanding more about the biology and the genetic changes within children's cancer, but always with an emphasis on bench to bedside translation, such that we may get some of these exciting therapies quickly to the clinic to help children. Next slide, please. And turning this back again to solid tumors or to brain tumors that we see in children with cancer, you can see that we have a relatively small number of patients who have this spectrum of cancers. And so it becomes very important to learn through genetic testing about the specific mutations or genetic changes that may drive these tumors, such that we may apply better therapies to the treatment of these small subsets of patients with cancer. Next slide, please. And this gives you a final example of some of the possibilities that are currently being explored in pediatric cancer. For the most part, this gives you an example of different therapeutic options that may be relevant to children who have solid tumors or brain tumors, as well as a few types of leukemia. But I think as we've learned more from the excitement of developing new targeted medications for adults with cancer, we are now hoping to apply some of these medications to children with cancer. And this is a very active area of phase 1 clinical trial investigation, where we are learning what is a safe dose of some of these targeted medicines in children. And I think we have learned that a lot of these medications are perhaps better tolerated in children than they are in adults. And sometimes we are able to drive the doses of these medications even higher than what is tolerable in adult patients with cancer. So where we remain in 2017 for precision medicine and pediatric oncology, I think there are particular challenges that we face that perhaps are unique for children that we don't see as commonly in adults. The first is that children's cancer is relatively rare, and there are a lot of different genetic mutations that ultimately feed into the development of cancer in children. It is sometimes problematic to access new drugs, particularly those with safe pediatric dosing. And so this is a very active area of collaboration and clinical research, both within children's hospitals as well as partnering with our pharmaceutical colleagues. And finally, getting children onto phase 1 clinical trials can be very challenging when children are very ill from a cancer that has returned or relapsed. And so we need to generally act quickly to understand the genetic changes within a cancer, as well as to match a medication and just determine if a patient may be actually eligible for a clinical trial. But I think this leaves us in 2017 with a lot of optimism. We certainly have had a lot of advances in next generation genetic testing, increased collaboration with our pharmaceutical partners such that we can now access very exciting and promising targeted therapies in pediatrics. And I think with continued emphasis on collaboration in early phase trials, we have great potential to rapidly advance precision medicine treatment strategies in children with cancer. And so I will conclude here that pediatric cancer is comprised of a very diverse group of individual subtypes, both liquid cancers, solid tumors, and brain tumors. We know the treatment really varies by the subtype, but is highly driven by the underlying genetic changes that cause the cancer. And we are fortunate now to have a variety of sophisticated diagnostic techniques that can help us to understand the different types of pediatric cancer and any particular underlying mutations, proteins, or signatures that may make the cancer more treatable in a more precise way. And finally, there are ongoing studies that are looking at finding such characteristics within pediatric cancers and helping us to place children on specific clinical trials or access specific drugs that may benefit their specific tumor type.
Thank you very much, everybody, for your input. I hope you learned today about the multifaceted approach to pediatric cancer and how important it is to make the right diagnosis and important it is to find the right treatment for your child. Massive Bio clearly can help families of children with cancer, and how we do so is by reviewing cases that you send to us from across the globe. We have experts in specific disease content areas and specialists in an area related to your child's cancer. We have diagnostic experts, pathology experts, and genetic and molecular experts as well. The combined approach of reviewing cases from a multidisciplinary group provides a report to the family and doctor generated, as well as a virtual tumor board where we can discuss the case to figure out what are the next best steps for your child. Families will often ask us specific questions about how should my child be treated? Are they getting the correct therapy? What other options are there for my child? Are there clinical trials that are available for my child? All of these things are things that Massive Bio can certainly help with. If there's any questions that you have, of course, visit us down below at our website. You can give us a call or email at any point.
Thank you very much, everyone. Now we have a few common questions from family members of patients that we would like to discuss with everyone today. First, I have a question for Dr. Freedman. The patient's parent asked, how can I enroll my child into a clinical trial?
That's a very good question. And enrolling on a clinical trial is a complicated process. What it does require is evaluation by a treating center or an academic institution that is offering or has that trial open. Again, if one of our recommendations from Massive Bio is that a clinical trial is appropriate, sometimes there are ways to help you determine which center is the best. But then a patient needs to get to the center that offers the trial. They need to undergo a physical exam and possibly laboratory, radiologic, or other types of testing to determine their eligibility. That means, do they meet the criteria needed to enroll in a trial? Just because a center has a trial open does not guarantee that a patient is eligible or actually able to start that trial or treatment. So if you have interest in a particular clinical trial, you can of course ask us, but otherwise you can contact a local center as well who can give you more information about what is required to get on that trial. But again, going through Massive Bio, we can provide a list of clinical trials applicable to your specific patient or child.
Thank you very much, Dr. Freedman. Next, we have a question for Dr. Tasian from the parent of a patient. My child's oncologist cannot decide whether we should have surgery or continue taking medication. How can we make an educated decision?
So that's a great question. I think it really, of course, depends on what the child's underlying cancer is, what its stage is, and what his response to therapy has been so far. A lot of times, oncologists are able to discuss with the rest of their team and really put brains together to come up with a common consensus. But I think as a parent, it's very important to ask questions and to really understand the nuances of their child's treatment to help them partner with their oncologist to make the best treatment choice for the child.
Thank you very much, Dr. Tasian. Now we have another question for Dr. Freedman from the parent of a patient. We have a baby who is 13 months old. We are told that he should begin treatment with chemotherapy immediately. Is that normal? Is there any way to avoid chemotherapy?
That is a great question, and I can certainly appreciate and understand the hesitancy of a parent to want to expose a baby to chemotherapy. In fact, chemotherapy is and has been the mainstay of treatment for pediatric cancer since the 1960s. Chemotherapy has come a long way since that time. In fact, there are people whose entire jobs it is to figure out how to appropriately dose chemotherapy for a young baby. So yes, chemotherapy, if recommended, is the correct option, and we are able to dose it so that the toxicities are low and the dose is clearly appropriate for the child. Is there a way to avoid chemotherapy? In certain types of tumors, there are other treatments that are employed, such as radiation or surgery. But if the treating physician feels or the current guidelines recommend chemotherapy, then I would go with the current treatment plan. Radiation is actually something that is concerning in young children less than 3 years of age, as we know that radiation can cause certain deficits to children and a developing brain. But again, those are more reserved for radiation and in patients less than 3 years old.
Thank you very much, Dr. Freedman. Dr. Tasian, the next question is for you. Can a child take the precision oncology and targeted therapy drugs that are used for adults? If not, why? Can we still leverage unapproved drugs if there are no other options?
So I think in pediatric oncology, we're very lucky to learn from our adult colleagues about exciting new medications that have often been tested first in adults to help find a dose or even to understand how well those medications may work for specific types of cancer. I think unfortunately sometimes we are a bit behind in pediatric oncology in being able to access those drugs specifically for children. I think this is getting better in the modern era of precision medicine treatment, however. And a lot of the medications we have now been able to study in a phase 1 clinical trial such that we can again define a dose that may be more appropriate for a child and help us to understand how well those medications may work specifically in children with cancer. Very rarely we are able to access exciting precision medicine drugs via a partnership with a pharmaceutical company, such that we may be able to get one of these medications specifically for a child with a specific genetic mutation in his or her cancer. But this is not always the case. So I think we have to interpret that on a patient-specific basis and see what classes of medications may be appropriate for the patient based on the genetic testing. And also if we have pediatric experience with a specific drug or class of drugs, or finally, if we are able to partner with a company in which there are good safety data in adults and perhaps be able to access and modify that dosing on a single patient basis for a specific mutation that perhaps has very good biologic rationale.
That's great. Thank you, Dr. Tasian. Dr. Freedman, we have another question for you. Do pediatric oncologists have specialties, or are they just general pediatric oncologists? Should we search for pediatric oncologist who specializes in leukemia? What is the difference between a general oncologist and a specialist?
Those are also very excellent questions to pose, and I can imagine the struggle to find the right doctor for your child. Pediatric oncologists are specially trained. We go through training, we do medical school, we do training specifically in pediatrics, and then we do something called a fellowship, which provides very directed training to become an oncologist and a hematologist. After that point, people are board certified to treat patients with cancer and other blood disorders. And sometimes in some institutions, people go on to have further training where they're very subspecialized into areas like leukemia, immunotherapy, or stem cell transplant. Many centers across the country and the globe, all oncologists will treat all types of cancer. At much bigger academic centers, people do focus because there's so many patients, you have to have experts in a certain content area. So again, there are certain centers where people only focus on leukemia or only focus on lymphoma. So I think in general, a general oncologist is able to diagnose and treat the mainstay or most common types of cancers in children. What we do find is that when patients relapse or their disease treatment gets very complicated, or they have other side effects necessitating intervention from an ICU or additional consultants, we do find that subspecialty type hospitals or larger centers are where patients and families go. And if there's a very particular reason for your child to be seen by a specialist, or treatment has failed, or there's a very particular question, then it's certainly appropriate to find a leukemia specialist or someone specializing in your child's type of cancer. I will tell you that fortunately the world of pediatric oncology is small, and many of the people across the globe do know each other or able to find each other. So if there are questions or concerns, many times your doctor may be able to reach out to other doctors for a similar type of, for help or questions.
Wonderful. Thank you, Dr. Freedman. The next question is for you as well, Dr. Freedman. How does Massive Bio help pediatric cancer patients?
So we talked a little bit about this before, but Massive Bio can review cases of your cancer for children. We have a multidisciplinary expert panel that includes specialists who focus on the disease and the oncologic treatment of that disease. We have people who are focused on the pathology review and can ensure the diagnoses are appropriate, can help us determine if any additional testing is necessary to better characterize the molecular or genetic features of the tumor, as you heard from both Dr. Tasian and Dr. Wertheim. Also, we have people who specialize in genetic and molecular areas to help us with some of the molecular characteristics that may influence treatment. We provide patients and families with a report, which is a summary of the recommendations made by our team. There is a virtual tumor board component where we discuss this with families if desired and with the treating physicians and help figure out what the best next steps are. Again, the nature of consults and reports provided by Massive Bio as a virtual tumor board vary, and it depends on the questions that are posed to the group, such as, is my child getting the right treatment? Do I need to consider other modalities of therapy? Are there clinical trials available? Or other things related to diagnostic dilemmas with your child's cancer.
Great, thank you. The final question is for both Drs. Freedman and Tasian. Why are more and more children getting cancer? Is there anything that we can do to prevent it?
I think the short answer to that is we really don't know why more children are getting cancer, with the exception of some genetic syndromes that make it more likely for a child to develop cancer. The causes of childhood cancer are truly, for the most part, pretty mysterious. There are a lot of epidemiologic studies and environmental studies ongoing right now that are helping us to try to get at do living close to power line kind of factors cause cancer, to having a lot of cold symptoms when you're a young child cause cancer. Does it matter if you're the oldest child in the family or the younger child? So I think those are great questions under good clinical studies, but we simply don't, for the most part, really know the answer to that question yet.
And I would just add that I think that it's important for parents to know that nothing they did or didn't do leads to their child getting cancer. And what I mean by that is, it's not that you left the window open. It's not that you fed them the wrong type of food. Cancer is unfortunate, and it happens spontaneously for the most part. Again, there are certain syndromes, as Dr. Tasian mentioned, but in general, unlike adults, there are no specific identifiable causes such as cell phones or smoking or things of that nature.
Great. Thank you very much to everyone for their participation in this educational webinar to honor Pediatric Cancer Awareness Month. We would appreciate the opportunity to help your child, so please feel free to reach out to us anytime, and a Massive Bio expert would be happy to discuss your specific case with you.